As a continuity of the last lecture, today we are going to discuss about in clinical pharmacy. Daltazyme, which is a beta blocker, and a verapamil, which is also beta calcium channel blocker. Both are the calcium channel blocker, or moderate inhibitor of the hepatic cytochrome 3A4 isoenzymes, and verapamil is also a potent P-glycoprotein inhibitor. Consult the BNF. What is BNF? British Natural Pharmacology. If you consult BNF, like a pharma guide in Pakistan, and manufacturer SPC for information on drug interaction. Also see E secondary prevention. They are given the reference of page number 325 to 26 for information on the same of the use of the statins. Third is anti-anginal agents. If beta blocker and calcium channel blockers (CCBS) are contraindicated or not tolerated, consider therapy with third line agents which may be added to existing therapy if symptoms are not controlled. Choice of agents depend on comorbidities, contraindication, and patient preference and drug cost. Nitrates are available in many forms. Oral nitrates are commonly used, but careful dosing is required to reduce tolerance. Isosorbate nitrate nitrates 20 to 120 milligrams orally twice daily. Isosorbate mononitrates modified release 30 to 120 milligrams orally daily. Nicorandil has nitrates like effect and is coronary dilator and is also potassium channel activator causing arterial vasodilatation. It may also have a cardioprotective effect, reducing the ischemic myocardial injury. It is licensed for use as a monotherapy, but is commonly used as add-on therapy to control symptoms. Side effects are similar to nitrates and also include GI ulceration, gastrointestinal ulceration. Nicorandil 5 mg to 30 mg oral twice daily, BD dose. Newer agents, ranolazine and ivabradine are used if symptoms are not controlled with or if side effects prevents use of established anti-anginal agents. Ranolazine mechanism of action is not fully understood. It inhibits slow sodium channel, reducing intracellular sodium and calcium, which reduces intracellular ionic imbalance during ischemia. Reduction in calcium improved myocardial relaxation. Left ventricular stiffness. Ranolazine does not significantly affect heart rate or blood pressure. Side effects include dizziness, headache, constipation, nausea. Ranolazine also causes QT prolongation and is contraindicated in patients with the long QT syndrome. Concurrent use with other drugs known to prolong the QT interval should be avoided if possible. Ranolazine is metabolized by the hepatic cytochrome 3A4 and cytochrome P2D6 isozymes and is also a substrate for the P-glycoprotein. Inhibitors of these enzymes will ranolazine's plasma concentration. Refer to the BNF, British Natural Pharmacology, and manufacturer SPC for full details. Ranolazine modified release 375 mg orally twice daily slowly to maximize of 750 oral twice daily. Liverbradine selective inhibits the current in the sinoatrial nodes following lowering. Heart rate and reducing myocardial oxygen demand. It may be used when beta blockers are not tolerated. Side effects include bradycardia, means heart rate decrease, heart block, means conduction block, and visual disturbances. It is important to avoid bradycardia in angina patients as this may be associated with adverse cardiovascular outcome. Treatment should be discontinued if heart rate becomes too low or symptoms of the bradycardia persist. Reference is given over here. Treatment should also be discontinued if there is no improvement in symptoms after 3 months. Liverbradine 5 mg orally twice daily, reduced dose in patient more than 75 years of age to 2.5 mg orally twice daily. Dose after 3 weeks to 7.5 twice daily in patient receiving 5 mg twice daily, or 5 mg twice daily in patient receiving 2.5 mg twice daily. Maximum dose is 7.5 mg twice daily. Secondary prevention. Secondary prevention treatment aims to reduce progression of the cardiovascular disease and improve long-term outcome. Antiplatelet agents inhibit platelet aggregation and may prevent formation of coronary thrombus. Consider use of aspirin to reduce risk of MI and vascular events in high-risk patients. Use should be balanced against bleeding risk and comorbidities. Aspirin 75 mg orally daily or clopidogrel 75 mg oral once daily if with tolerance of aspirin. ACE inhibitors are venous and arterial vasodilators, reducing preload, afterload, and improving cardiac output. Consider use of the ACE inhibitor in patients with the angina and diabetes. ACE inhibitors should be offered or continued to people with other coexisting conditions, for example, hypertension and heart failure, in line with relevant NICE guidance. Ramipril, another drug, 1.25 to 2.5 milligram orally once daily to 10 milligram oral once daily as tolerated. Angiotensin receptor 2 antagonist ARBs may be an alternative if patients are intolerant to ACE inhibitor, but there are no clinical outcome studies of ARB in angina. Statin should be used in line with NICE guidelines on lipid modification. Start high-dose statin therapy in people with cardiovascular disease. For example, atorvastatin 80 mg daily. Use a lower dose if there are potential drug interaction. A high risk of adverse effect or if patient preference. Concurrent use with the potent cytochrome 3A4 inhibitors may inhibit metabolism of certain statins, especially simvastatin, resulting in statin concentration and risk of myopathy and rhabdomyolysis, means breakdown of the muscles. Refer to MHRA guidelines, covers 212 for full advice of particular importance with respect to other cardiovascular drugs is the maximum recommendation dose of 20 milligram of simvastatin when used in conjunction with amino amiodarone, amlodipine, or diltiazem or verapamil, these calcium blockers. Patient taking simvastatin should also avoid grapefruit juice. Refer to the BNF and the manufacturer SPC for full detail on statin interaction. So statin interaction is also interacted with some fruits like grapefruit. So we should not take with the grapefruit juice. Now we discuss about hypertension. Treatment of hypertension. High blood pressure or hypertension is a major risk for stroke, means breakdown of the vessels in any part of the body. MI, myocardial infarction, chronic kidney disease, CKD, heart failure, peripheral vascular diseases, cognitive decline, and premature death. It is one of the most preventable causes of the premature morbidity and mortality in UK. Risk factor for developing hypertension includes age, ethnicity. Hypertension is more common in patients of Black, African, Caribbean descent. Obesity, lack of physical activities, excess salt intake, excess alcohol intake, stress, diabetes, sleep apnea, and chronic kidney disease. Primary hypertension, which accounts for 795% of cases, is defined as sustained high blood pressure with no obvious cause. Secondary hypertension, which accounts for remaining 5% of the cases, is diagnosed when a specific cause can be identified. For example, renovascular disease, pheochromocytoma, it's a tumor on the kidney which produces more adrenaline. Primary hyperaldosteronism, Cushing syndrome, we call it, moon phase. Certain medicine can cause hypertension, like NSAIDs. NSAIDs means non-steroidal anti-inflammatory drugs like brufen, diclofenac sodium, mefenamic acid, including COX-2 inhibitor, celecoxib, and few more drugs are available in the market. 5 active 1 receptor antagonists like sumatriptan, rizatriptan, corticosteroids, oral contraception, topical or oral decongestants, cyclosporine, recreational drugs for cocaine, amphetamine, ecstasy. They also causes hypertension. Diagnosis of hypertension. Hypertension is typically asymptomatic and thus those diagnosis is often made during opportunity screening for initial assessment measurement of BP in both arms. If the difference in reading is more than 20 mmHg, then repeat measurement should be taken. If the difference remains, subsequent measurement should be taken from the arm with higher reading. If clinical BP is 140 by 90 mmHg or higher, offer ambulatory blood pressure monitoring to confirm the diagnosis. Home blood pressure monitoring. Home blood pressure monitoring (HBPM) can be considered as an alternative if the patient is unable to tolerate ABPM. Diagnosis of hypertension is confirmed if average reading from ABPM or HMBM are more than 135/85 systolic and diastolic. So the difference between home blood pressure and ambulatory patient who comes to the hospital, we have to consider few things, right? So we have to consider all these factors while giving any medication to hypertensive patient. We're still awaiting confirmation of the diagnosis, further investigation for target organ damage and a formal assessment of the cardiovascular risk should be carried out. Means investigation for any damage of any organ like heart or kidney. When assessing cardiovascular risk, it is important to consider a patient's overall risk profile. Various risk tools are available which use gender, age, smoking status, diabetes status, lipid profile, and BP to estimate an individual 10, 10-year risk of the developing cardiovascular diseases. If hypertension is not diagnosed, clinical BP should be checked at least every 5 years or more frequently annually. If BP is on the higher side of normal, for example, close to 140/90, systolic 140, diastolic 90, then we see the classification of hypertension. Stage 1, stage 2. Stage 1 hypertension, clinical BP 140/90 mmHg or higher, are subsequently average daytime ABPM or means ambulatory patient who comes to the hospital or at home, or average HbPM is 135/85 or higher. Stage 2 hypertension, clinical BP 160/100, systolic 160 and diastolic 100 or higher in subsequent. Average daytime ABPM or average HbPM is 150/95 mmHg or higher. Severe hypertension, clinic systolic blood pressure 180 mmHg or higher, or diastolic, clinical diastolic BP is about 110 mmHg or higher. Non-drug treatment, non-pharmacological measurement to reduce both blood pressure and cardiovascular risk should be offered to all patients with hypertension. Effective measurement includes smoking cessation, stop smoking, weight reduction in obese patients, reduction of excess alcohol intake defined as more than 14 units per week for men and women, healthy diet and regular exercise, moderate sodium restriction by reducing sodium intake, no added salts diet or use of the salt substitutes, management of sleep apnea, stress reduction and relaxation therapy, and avoiding excess consumption of caffeine-rich products. So these are all the precautionary measures without drugs. If we follow these instructions, we can control hypertension of a patient, and hypertension is a silent bomb because it can blast any time, and the consequences or the result of hypertension is more dangerous than hypertension itself because it can damage to any organ. It can cause a stroke in the brain, heart or lung, and this is an alarming situation for a patient with hypertension. So we have to consider all these things before we go in for examining or recommending any drug to the patient. We can treat patient with the drugs and we can treat patient with non-drug. With non-drug, I have mentioned you about 10 points. And with drugs, we have seen a lot of drugs like calcium channel blocker, beta blocker, vasodilation, AC inhibitors, and few new products, selective beta blockers. So, there are a lot of treatment are available. Then we have to select among them. This is all for today. See you in the next lecture. Thank you.